Assalamu alaikum wa rahmatullahi wa barakatuh. I will talk today about the challenges in the asthma management and update. These lectures are directed for all healthcare workers, especially medical students, inter-resident medical residents, and respirology specialists and consultant in respiratory medicine. Family medicines and internal medicine and GPs can also have a huge benefit from this series of respiratory lecture. We will talk about them from today. The first is about a common disease in respiratory medicine, which is an asthma. Asthma is a huge burden of disease in our community. We, as a physician, facing a lot of challenges in the management and update of these patients. The main objective is asthma definition and global burden and a local burden therapy goals in asthma management and challenges facing all clinicians in the clinic to treat those patients. Definition of asthma. As Virginia guideline, which is the main global initiative for asthma guidelines in worldwide, the asthma is defined as a heterogeneous disease. This word is very important landmark in the asthma population. Heterogeneity means differences, and usually it is as an easy definition chronic airway inflammation, which manifested as a respiratory symptoms, which is coming and going as wheeze, shortness of breath, and chest tightness and cough. These symptoms are vary over time. It is different in intensity, severity, variable, i.e., reversible, closed and opened airflow with a reversible documented physiology as expiratory airflow limitation. So the most really important word to be identified and memorized and categorized in those asthma population is the heterogeneity. Asthma is different between each patient, i.e., this asthma patient does not dealt as similar as another asthma patient. Very different in severity, variable, come and go. These symptoms either spontaneously or treated or resolved by medication. This word of heterogeneity is very old word in asthma population since, as you can see, 76 is reported that the heterogeneity of asthma in adult population is identified and individualized approach in diagnosis and treatment is needed. So it's not a new concept, but we adopted it very recently and we need to individualize the management for those patients differently. So the patient with asthma are prevalent. More than 25 million patients have asthma in the United States, and those patients have around 9.8 million attack of asthma exacerbations. And the healthcare use emergency department visits and the inpatient stay costing a lot for all the institute worldwide. As you can see, there are a lot of clinical and socio-economic burden of asthma in Saudi Arabia as one of the Middle East countries. We in our country have 50% of asthma experiences at least one exacerbation in a year. So adherence, asthma severity identification, and the level of using SABA are increased as those patients have more exacerbation. And with many studies, we can conclude that the asthma control is poor across disease severity, i.e., it's poorly controlled mild asthma, poorly controlled moderate asthma, and poorly controlled severe asthma. And that's why, because we don't really individualize the treatment. Among the Saudi adult, a very recent data in August 25 conclude that asthma may go up to 68%, and in some study, well-controlled asthma patient as few as 3% only. That's how the airway of asthma patients looks like. This is the open lumen. As you can see how much is narrowed lumen with excess mucus, increased inflammation, increasing these smooth muscle tightening and cause severe bronchospasm, unrelaxed smooth muscle, closing the airway in symptoms and exacerbate. Because of this chronic inflammation, we need in asthma population to stop this inflammation. But we as a clinician or doctor seeing those asthma still facing a lot of challenges. Why asthma still killing? Because we have a high rate of poorly controlled and poorly monitored disease. We are still continuous unacceptable level of morbidity and mortality from this disease. We have a gap in the quality of diagnosis and ruling and confirming the diagnosis and ruling out the other differential diagnosis. We have a low level of patient adherence and inhaled error technique use. I define the challenges in asthma management as a challenge one in diagnosis those patients. The respiratory symptoms can happen in a very wide scheme, as you can see, ranging from intrathoracic causes, extrathoracic, upper respiratory tract and lower respiratory tracts. The lower respiratory tract, either proximal airway or a distal airway, proximal like central airway obstruction, or a primary tracheal papilloma or tracheomalacia, or a distal airway like bronchiolitis, bronchiectasis, COPD, ABBA, or other disease. As you can see more, even heart failure can give a respiratory symptom, metastatic diseases or cancers, presence of foreign body, or structural abnormality like congenital cystic fibrosis or primary dyskinesia, i.e., we have a respiratory in a respiratory medicine, a huge of diseases can give these symptoms. How we confirm it? It's a correlation of the patient's symptoms by the history, physical examination, and further investigation. Not all the patient need to have a chest X-ray to diagnose asthma, but if we have patient like this patient, 50-year-old man came with a history of a prolonged asthma, but what happened? Is diagnosing this patient for a long time as asthma. We did a chest X-ray. When he came to me, he's a 50-year-old man with some history of smoking and some questionable asthma. I did a chest X-ray which is showing this clear hyperinflation. As you can see, the lung is inflated, expanded, and flattening of diaphragm is seen clearly in this case. As you can see, and there is increase of the anteroposterior diameter. But still, is this an asthma with a flattening also in the ribs, as you can see here, and elongated heart? But there is some questionable reticulation in between and here in the upper lobe, as you can see. Further CT revealed a mixed interstitial lung disease and small area obstruction, which is it's not just asthma, and that's why we was facing uncontrolled symptom of this case. Another case of a chronic respiratory symptom diagnosed of asthma for 10 years, and this unfortunately was one of the physicians of the family medicines in the other institutes. This patient was diagnosed for 10 years as asthma. No clear chest X-ray done for him for the last 10 years with this chronic respiratory symptom, which is on and off coming, not resolved, with a progressive shortness of breath. This patient's chest X-ray, as you can see, reveal bilateral, diffuse interstitial, mainly reticulonodular, predominantly reticular interstitial infiltrate with a clear reduction of the lung volume, both sides. And this reticulation can show some traction bronchiectasis in this area, HRCT, so interstitial lung disease, even UIP pattern, unfortunately, and the further diagnostic test reveal CTD, connective tissue disease related interstitial lung disease. More testing reveal a mixed connective tissue disease was having some RA with scleroderma. His echo also show a presence of pulmonary hypertension, this patient started aggressively for the interstitial lung disease related connective tissue disease management from steroid, second line of immunosuppression with antifibrotic and pulmonary rehabilitation, even so referred for pulmonary or lung transplantation clinic. Another unfortunate case, which is diagnosed initially as asthma, revealed bilateral, as you can see, aggressive nodular infiltrate. Finally, it's a case of alveolar carcinomatosis. Again, another case of cough. And this patient was a young man, received some radiotherapy before 7 years back, came with a chest x-ray, show a different scenario of radiation pneumonitis as an area of radiation post for a lymphoma treatment. Asthma diagnosis. So please, after all of these jump, confirming diagnosis is a must. Ruling out other differential diagnosis is a must. And that's all about the challenge one. Precision medicine is the aim of all medicine, not only pulmonary medicine, not only asthma, it's all medicine. We need a stratified medicine, targeted medicine, the concept of B4 medicine, predictive, preventive, personalized, and participatory. And that's which take us to classify an asthma phenotype. This phenotype's identification is the cornerstone of all the ongoing new update of targeted medicine for the asthma treatment. So we classify our asthma population based on the history, clinical features starting from the disease onset, early, late, childhood, adulthood, atopic history, presence of allergic rhinitis, skin allergy, food allergy, drugs, and disease progression. Pathophysiological pathway. We would like to know the airway inflammation type by the inflammatory indicators, markers, and the molecular pathway. We need to know markers also for the response of treatments. And the classical scenario is those cases coming from history, as this is a 20-year-old asthma. She have one hospitalization past year. She's using high-dose inhaled corticosteroid, LABA and LAMA, long-acting beta agonist, long-acting muscarinic, antimuscarinic. She's still waking up at night in spite of those medication due to an asthma symptoms. She had intermittent wheeze, shortness of breath, impacting her quality of life and daily functionality. Her spirometry reveals forced expiratory volume per second of 60% predicted, and her eosinophil count range from 420 to 35, and her IgE is 140. And those are the inflammatory markers and the severity of the disease physiologically, and the asthma control test assessment with a history of severity of the disease, which is concluding the individualized management needed for such a case. So the phenotypes of asthma are identified with many studies as early onset allergic, for example, with a history of food allergy, atopic dermatitis, and allergic rhinitis. Late onset minimally atopic eosinophilic, which is a chronic rhinosinusitis, nasal polyp, and severe airway obstruction. Late onset non-eosinophilic, which is somehow poorly characterized with a significant lower respiratory tract infection and presence of GERD. So associated comorbidities are very important, like nasal polyp, GERD, and as mentioned, allergic rhinitis. Because when you fit your patient in these tables with a severity also identification based mainly on the FEV1 and the ER visit and admission from mild, moderate, and severe, you will fit your patient to the inflammatory cascade. And that's how the trigger when or pollutant or microbes or smoke coming and triggering the inflammatory cascade. Here are the interleukins runs everywhere, and those interleukins are recruiting dendritic cells, mast cells, B cells, and macrophages too, and eosinophil. And those all cells are causing all the complications in the airway from the bronchospasm, increased sputum production, and these symptoms the patient manifested with cough, shortness, breath, and wheeze. So the identification of the inflammatory marker and the pathways to choose the best treatments fit for this patient based on the scheme are a must with a new generation of treatment in asthma population. We need, as a healthcare worker, to optimize early diagnosis and management of these patients to improve the outcome. We need to have a written action plan for those patients because the evidence say 37% only of the healthcare worker writing this action plan for their patient. We need to use a validated asthma questionnaire, and we want to use an estimated proper medication use by objective measures. And to go on a proper therapy goals in asthma management, we will use inhaler. Over the past 50 years, asthma management has significantly advanced, starting from a simple MDI with Ventolin from 1970 or in 69, then with improvement with the years, as you can see, very nice improvement and changes of the MDIs, different devices. We have Turbohaler, we have Rispemed, and we have a new different, very nice biological therapy, which is a one injection from 2003. This biological therapy introduced mainly with the father of biological therapy in asthma, which is the omalizumab anti-IgE. Further on now, we have like more 15 years history of using the biological therapy with a very good outcome. Others new, we have interleukin 5 receptors and 4 to be stopped further symptoms or uncontrol of the disease. And why we would like to achieve a long-term goal asthma management. We want the symptom control and we want the risk reduction. We want to ask the patient about their own goals regarding their asthma. We want to have a good communication strategy between us and the patient. That's an essential line of management. Building a trust, building a bond. We want to have appropriate management to consider all the effect and impact on the healthcare system, medication availability, and cultural and personal preference and availability in the health institute. We want to have a more green. We want to remove more reds from the asthma management history. We want to improve symptoms, daytime symptom, nighttime awakening, management of the all comorbidities, and improving the lung function. We don't want to have more exacerbation. More use of rescue medication is not recommended. We would like to reduce the adverse effect and treat related adverse effect. We want to reduce the emergency visits, admission, and hospitalization. And that's all now depend on the current treatment recommendation of the global and national guideline agreements, and all the agreement now coming with importance of the use of regular inhaled corticosteroid. Worldwide recommendation. You can see studies from all national guidelines. They are now recommending to use inhaled corticosteroid use.